Welcome to the Health Workforce Technical Assistance Center's webinar series. This presentation is entitled, How Can We Transform the Workforce to Meet the Needs of a Transformed Health System? And it was presented by Erin Fraher on April 9th, 2014.
Now, I'd like to take a few moments to introduce today's presenters. Dr. Fraher is an assistant professor at the School of Medicine at UNC Chapel Hill, holding joint appointments in the Department of Family Medicine and Surgery. Dr. Fraher has spent most of her career developing local, state, and national capacity for evidence-based workforce policy. She is frequently called upon by the legislature's national health policy organizations and educational institutions to address health workforce concerns and needs. Her current research focuses on the need to retool and reconfigure the health workforce to meet the demands of this transforming health workforce system. And at this point in time, I'm going to go ahead and turn it over to Erin. After the presentation, you may ask questions using the chat panel on the right of your screen. Make sure you send your questions to all panelists to ensure that they have an opportunity to be answered. Also, when the event ends, you will be directed to a short evaluation survey. So please, take a few moments to provide us with your feedback. We appreciate it. Erin, you there? You ready to go?
I am ready to go, David. Thanks for the introduction, and hello, everyone. I want to start by acknowledging that the work that I'm going to present is funded through a cooperative agreement that we have with the Health Resources and Services Administration. And I'd also like to acknowledge that this work was done with two fantastic graduate students here, Rachel Makta and Marissa Morrison. So today I want to talk about health workforce planning in the new world of health reform. So one of the things that strikes me when I'm out there is everyone's talking about payment and new models of care, and how do we align those things to achieve the triple aim. I don't know about you, but I'm not hearing a whole lot of people talking, how do we transform our health workforce to achieve the triple aim? And so we've been talking a little bit about retooling the health workforce. It occurred to me when I was preparing for this presentation is that we also have to retool ourselves. The health workforce researchers and policymaking community needs to retool. So that's the topic of today's conversation. Because with or without health reform, the current system is not sustainable. Here in North Carolina, we've made a decision not to expand Medicaid, so we're one of half of the states that have not expanded Medicaid. And the thing is, whether or not we expand Medicaid, whether or not we fully embrace health reform, the pressures out there are so significant on both the demand side, with an aging population, increase in chronic disease, health system consolidation, proliferation of new models of care, payment policy changes, and rising patient expectations. All of those things are on the demand side. On the supply side, you all know this better than I do. Workforce deployment is rigid, right? Turf wars abound. Think about the turf wars in your own state. Specialty and geographic maldistribution is a huge issue, and productivity is lagging. So whether or not your state embraces health reform, those are your pressures. This chart is actually healthcare employment reference to the year 2000. And you can see a really rapid growth in healthcare employment relative to non-farm employment. So here's healthcare employment growing very rapidly, basically flat non-farm employment over time. But you know, the thing is, we've got more people in healthcare, but people are doing less, basically. We have more people doing less. So of the $2.6 trillion spent nationally on healthcare, over half is on wages. But this nice paper by Kocher and Sahini in Rethinking Healthcare Labor in the New England Journal of Medicine really pointed out that relative to other sectors in the economy, healthcare and social assistance have negative productivity relative to manufacturing, retail, trade, and this is a major concern for folks. So let's go forward and look into the future. So when I think about health reform and the new world of health workforce planning, when I think about all that's out there, I think it's more about a redesign of how healthcare is delivered and less emphasis on who delivers care. And I'm going to drill down on what I mean by that. I want to talk a little bit about patient-centered medical homes and accountable care organizations and technology, because I believe that those forces are really what's going to really require us to have a much more flexible workforce. And right about now, you should be thinking, what is she talking about, flexible workforce? workforce, so we'll dig down a bit on that.
One for more.
But first, let's talk about the characteristics of accountable care organizations and patient-centered medical homes. What are their key characteristics that they share? Basically, you all know this. The emphasis is on primary and preventative care. Healthcare is integrated between medical subspecialties, home health agencies, and nursing homes. But a thing that people often miss, and think about it in your own work, is people talk about healthcare being integrated. They talk about integration across healthcare settings. But I think sometimes they miss the point that the patient starts their healthcare journey in the community, in their home. And so to achieve true integration, we need to be able to integrate community and home-based services with healthcare. Technology is used to monitor health. We all know these payment incentives that are supposed to promote accountability, move towards risk-based and value-based models of care, and all designed to achieve this triple aim, right? These are the common characteristics. So what is this going to mean for the health system and health workers? I stole this quote from CMMI when they were putting out their Healthcare Innovation Challenge. I stole it with accreditation, as academics do. I loved this quote. Is that a transformed healthcare system will require a transformed workforce. And the people who will support health system transformation for communities and populations will require different knowledge and skills in prevention, care coordination, care process reengineering, dissemination of best practices, team-based care, continuous quality improvement, and the use of data. So CMMI recognized that they had all these new models of care and that we were experimenting with new payment models and that the workforce itself needed to be retooled, that it wasn't up to snuff. And there are all these, let 1,000 flowers bloom, right? If you look out across the landscape right now about all these experimentations that are going on, these are just a few, the community-based care transitions programs, the shared savings programs that some of your states may be participating in, the CMMI initiatives such as the Multi-Payer Advanced Primary Care Demonstration Project, the Comprehensive Primary Care Initiative. We've got lots and lots of private payer initiatives out there, such as Cigna's Collaborative Accountable Care Organization. In my own state here in North Carolina, Blue Cross Blue Shield of North Carolina is actively engaged in some private payer initiatives. And the VA, let's not forget the Veterans Administration. You know, as a integrated closed system, they actually are doing tons of innovative things around patient-centered medical homes. But here's my concern, and this has been my concern from the beginning. Are we harvesting the lessons learned from these experiments about redesigning the workforce? I don't know about you, but I don't think we're doing as well as we could on that. So what do they mean? What are these changes in new models of care and payment mean for the workforce? And what in the heck do I mean about a flexible use of workforce? What are the dimensions of flexibility? I believe the dimensions are that existing workers will take on new roles in new models of care, that existing workers will shift between employment settings and between health and community settings, and I'm going to talk about that, that existing workers will move between specialties and they'll be forced to change the services that they offer, that new types of health professionals will emerge and they'll do new functions, and we all know that's emerging at a rapid pace. And I really do hope that number 5 comes true, that there is broader implementation of true team-based models of care. So yeah, Erin, great, let's retool the workforce. But hey folks, we need to retool ourselves. We need to retool workforce research. And I'm going to spend the next portion of this presentation talking about retooling ourselves. And what do I mean by that? I mean, we need to rethink the questions that we as workforce researchers are asking. We need to rethink the policies and programs that we design and implement to shape the health workforce. And we need to rethink our partners. Who are we partnering with? So what I want you to take away from this webinar is, yeah, Erin, we need to retool the workforce. But I also, maybe more importantly, want you to take away from this webinar, we need to retool, rethink the way that we're asking and researching workforce issues. So reframe number 1, I call it from numbers to content. I don't know about you in your state or federal, how many times a week do you get asked the question, how many nurses are we going to need under health reform? Will we have enough physicians? What's going on with pharmacists? Do we have enough? Do we have enough? And every time you look at the newspaper, someone is screaming shortage. Because shortage makes headlines. People love to talk about numbers. I don't think that's the right question. I think the question is not have enough. But do we have the workforce with the right skills and competencies needed to function in new models of care? It's a question of not numbers, it's content. Because health professionals are taking on new roles, right? We just talked about PCMHs and ACOs, right? They're emphasizing care coordination, population health management, patient education, all those things that we talked about. And there's so much enthusiasm for new models of care, but limited understanding of the implications of those new models and that new deployment for health workforce training. And more importantly, one of our graduate students who's doing an extensive literature search on all of these topics said to me the other day, you know, Erin, I'm out there looking at the recent literature, including the piece that just came out in JAMA by Fraher on PCMH implementation in Pennsylvania, and it didn't show the huge expected gains in quality and lower costs that we expected. And she said, you know, what if these new models of care are not showing the expected outcomes because the workforce was not systematically included in the redesign efforts? And Bodenheimer's been working on this for ages and has really built up a quite impressive bit of literature and understanding of this through his work. And basically, you know, what they found is workers with the right skill and training are absolutely integral to the ability of new models of care to achieve these goals that they're supposed to be achieving. So, folks, we can talk about new payment models, we can talk about models of care till we're blue in the face. But until we start talking about what specifically do those things mean for the workforce in terms of training, I'm pretty certain that we're not going to achieve the goals that we want to achieve with those new initiatives. Okay, that was numbers to content. But do you also notice people love to talk about provider types? I think it's about provider role. So the typical question is, how many nurses do we need? How many dentists do we need? How many pharmacists do we need? Do we have enough dentists? What if we start talking about the roles that are needed? What if we talk about, you know what, we need more care coordination. We need more patient engagement. We need better care transitions. We need better use of EHRs for population health management. What if we start with the question of skills and then roles and then talk about thinking about
then pound.
The different ways in which we can meet those needs with different skill mix configurations. So what do I mean by that? Look at medical assistants. Look at medical assistants in your own state and think about what's happening in other states. This is I am not doing any perfect justice to this, actually. The roles of MAs are expanding amazingly. And, you know, Sue Chapman out at UCSF is really probably the leading expert in the country on this. But it's really interesting to look at the different ways in which people are using MAs, right? MAs are doing both these front and back office duties. They're doing immunizations, except in some places like New York where they're not allowed to, blood draws and other clinical tasks. They're acting as health coaches, right? They're conducting home visits. They're managing population health. They're calling the diabetic patients and getting them into the clinic. They're working with EHRs and managing registries. And in some of the work, they're acting as scribes, right, following physicians around, writing everything down so they can get it into the electronic health record. So MAs, in the way that they're utilized in different places, is very different and very different roles. In the same way that care coordination roles for nurses are very different in very different places. So nurses are doing all sorts of care coordination, and they're doing it for the frail elderly, they're doing it for cancer patients, they're doing it for many different kinds of patients, and they're managing these transitions from acute to ambulatory and community. They're creating care plans, they're engaging in education, and really engaging the patient and family in the care plan. They're doing outreach and population health management, and they're connecting patients with community-based services. So these are the functions that they're doing. But whether a nurse does these functions, but what if the practice doesn't have a nurse? The physician might be doing these functions. Other places in MA might be doing it. Some places a social worker might be doing it. To me, the question is not how many of what type, it's the role and what are the key skills and competencies we need to achieve. Third reframe, from a focus on the pipeline to a focus on retooling the existing workforce. Have you noticed that when people think about retooling, they immediately think, how do we need to change the curriculum for the students in the pipeline, right? Everyone loves a shiny new grad. They're exciting. So lots of curriculum revision going on right now for students in the pipeline. but it's the 18 million workers already employed in the healthcare system that need to be retooled. Think about it. If you just change the pipeline, those people are filtering in every year, you're not going to have the same impact as if you take the 18 million workers already in our U.S. healthcare system and retool them, right? So we really need to be focusing much more on the existing workforce, right? Because rapid health system change is going to require not only this focus on these shiny new grads, but also identifying and codifying these emerging health professional roles, right? We've got to understand, what are these roles? What is care coordination? What is that function? What is population health management? These things they're becoming more codified, but we still have some work to do. And really importantly, we need to develop more community and home-based clinical placements, right? And we need more innovative kind of model interprofessional practice sites. Because one of the things that strikes me when I look at the health workforce, and I look at changes in payment policy and the whole shift from fee-for-service towards bundled care or risk value or episodes or capitation or these fines that are penalizing hospitals for readmission, what are those going to do? They're going to shift healthcare to less expensive settings, right? Hospitals are expensive. Treating patients in hospitals is an expensive business. So we're going to have to move care up the pipeline, back into ambulatory, back into community. And as care starts shifting, what happens next? The workforce shifts, right? I was at a meeting the other day where a CEO of a major health system stood up and said, thank you for bringing this up, because they're having to shift, like, I think it was a couple hundred nurses from acute to ambulatory settings, and they had no training in place to be able to do that. If you're a nurse and you've always worked in protocols and you did all your rotations in an inpatient setting and you've only ever practiced your entire life in an inpatient setting and suddenly you're thrust out into an outpatient setting, you have to be retooled. You have to really think about the new skill sets and the new way in which you are going to function. So this is critical because we typically train the workforce in inpatient settings. We've really got to expand these outpatient and community-based settings. But what about getting people into people's homes, right? Increasingly, patients are being cared for in their home. So the workforce needs to be prepared to meet the patient on their own turf. And the existing workforce will also need more career flexibility, right? I mean, how do you train for a workforce that you don't know where the health system is going to be? I love this quote from NHS England, National Health Service in England. For some of you who know, I spent a year there studying what they were doing, and this quote really jumped out at me. Clinicians want well-defined career frameworks that provide flexibility to change roles and settings, develop new capabilities, and alter their professional focus in response to the changing healthcare environment, the needs of patients, that's important, and their own aspiration. And to do that, we're going to have better and seamless career ladders that allow workers at all levels, at all education training levels, to seamlessly move between different educational modules and different ways of gaining this retooling and retraining so they can move between settings, services, and patient population. I don't know about you, but I don't think we have very seamless career ladders. Reframe number 4. From a focus on workforce planning for specialties to workforce planning for patients, have you ever noticed how many people like to ask, how many primary care providers are we going to need? How many general surgeons are we going to need? Do we have enough geriatricians? Do we have enough vascular surgeons? What if we started by asking, what are the patient's needs for care, and how could we redesign the workforce to better meet those needs? Right about now, you should be rolling your eyes thinking, yeah, Erin, utopian. But you know what? Our friend Des Gorman and the folks in New Zealand have done this, and I'm going to talk about this. But first, I want to talk about the fact this is some work that Lloyd Michener has been really emphasizing at Duke, is planning to support a workforce for health, not a health workforce. And that's not just a semantic issue, right? If we really are going to care about patients upstream before they end up in acute settings, we're going to have to expand our workforce planning efforts to include workers in community and home-based settings. We're going to have to start thinking about the roles of social workers and the overlapping roles in care coordination between nurses and social workers. We're going to have to start talking about patient navigators much better, in much more clear terms, and codifying who are these people, what are they doing. Community health workers, a lot going on right now, a lot going on with community health workers. But as I'll talk about, there's no standard definition of a community health worker, and maybe there doesn't need to be. So we need also better integration between health workforce and public health workforce planning. Who is in the public health workforce? Challenge yourself to ask yourself that question. I don't know. We get asked this question all the time. So we need to think about better integration of kind of typical health workforce as we think of them in the public health workforce, so that we're planning for population health and not for the needs of professions. So I mentioned Desforman in New Zealand, and they're doing some really neat work engaging clinicians and patients. And I'm a big fan of this work because they're trying very hard to transform care from the ground up instead of the top down. They're asking clinicians and they're asking patients to construct these idealized patient journeys in mental health, aged care, primary care, maternity services, rehab, eye health, and musculoskeletal health. And what they're doing is designing these ideal patient pathways by disease area, and then identifying the workforce changes that would enable these new models of care. Let me be more specific about what they're doing. So the process involves asking clinicians, taking a group of clinicians and saying, okay, for diabetes care, tell me the typical patient trajectories. How do they work? What do they look like? And typically, you'd be surprised, they can come up with a pretty manageable number of cases and trajectories that describe the typical patient's journey in diabetes. And they do this, and they describe the typical, what's happening now. You know, the patient does this, and then they see this person, and then they get this, and then they go there. And then they sit them down with the patient and say, what's an ideal journey? What would the ideal journey? Think completely outside the box. Don't worry about payment. Don't worry about scope of practice. Don't worry about training. Don't worry about any of that. What would be the ideal journey so that the patient would get the highest quality, highest patient satisfaction, lowest cost care? And they do this and create these ideal journeys. And they've done this for a number of these areas. And they say, whatever the ideal journey is, it has to meet a doubling of demand. That's pretty ambitious. At 140% of the cost with no decrease in access or quality. And then they sit down with workforce experts and identify what workers, infrastructure, and system changes are needed to enable those scenarios. And they also identify the barriers and start to address those barriers. And they've actually had great luck in actually redesigning the role of pharmacists in outpatient settings and the use of warfarin. They've done some really innovative things because they sat down and asked the patient. They ask the clinician, what should this patient's journey look like? And that's really enabled them to think from the patient's perspective rather than the system perspective. Number 5, from a focus on workforce planning within care settings to workforce planning across settings. I don't know about you, but typically we're asked, how many doctors, nurses are we going to need in hospitals or in outpatient settings or in long-term care settings? Think about it. We workforce plan for the boxes, for the settings. What if we workforce plan from the patient's perspective? And what is the patient most concerned with? They're most concerned with integrating care and managing their transitions between home and outpatient and acute settings. So it's the workforce that is addressing those transitions that's absolutely critical in getting often missed in this discussion. But if you look at the CMMI initiatives that are funded, we just went through and pulled out a bunch. A good chunk of them in these new types of health professionals are focused on exactly that issue, managing transitions in community, right? Patient navigators, nurse care managers, care coordinators, community health workers, care transition specialists, living skills specialists, patient family activators, home health aides, peer and family mentors, right? I mean, that, if you think about where the workforce is exploding and growing and new roles are emerging, it's in between the settings. It's managing those care transitions because we know that if we reduce bad transitions and we reduce unnecessary hospital admissions, we'll lower costs, have happier patients, and higher quality outcomes. So let's plan between the boxes rather than in the boxes. Retooling, how do we get there from here? So let's go back to my initial framing for this presentation. I said we need to retool the workforce, and we need to do that along education, reimbursement, and regulation, and we need to make it much more responsive to changes in frontline healthcare delivery. But you know what? Those of us who are health workforce researchers and policymakers and government agencies and PCOs and rural health offices and AHECs, we got to retool what we're doing too. Because our work is going to be critical to developing the evidence base necessary to inform policy changes. I don't know how it works in your state, but if there's no evidence, we just rely on anecdote. And we've got a lot of work to do to figure out what are the workforce implications of these new models of care. I wouldn't be a good academic if I didn't cite my own paper, so now you can roll your eyes again. So this was a quote that Tom Ricketts and I had in our paper on reconfiguring the health workforce in health affairs. And we said revolutionary changes in the nature and form of healthcare delivery are reverberating backward into education as leaders of the new practice organizations demand that the educational mission be responsive to their needs for practitioners who can work with teams in more flexible and changing organizations. But they can demand all they want. The education system is lagging because generally it remains largely insulated from health system reform. So academic health centers, other places, you've got the education wing on one side and healthcare delivery on the other. And often those two sides are not talking to each other. We need absolutely closer linkages between healthcare delivery and the education system for four-year and post-baccalaureate education, for community colleges, and also for continuing education. How are we going to know what the demands, the retraining demands are of the healthcare system unless we ask the frontline healthcare delivery folks? We need much better integration. And we need to redesign education so that it's easier for people to retool, right? We need to think about training the individual health professional for these new roles. And that training, remember, this is the 18 million workers already in the health system. For them to retrain, it's going to need to be convenient. The timing, the location, if I've got to travel, I'm not going to do it. If it's during work time and I'm not going to get paid, I'm not going to do it. If I'm not going to get paid to do it, I might not do it, right? So then financial incentives have got to be aligned. This next bullet is something I bang my head against the wall about, and I wonder your thoughts too. So let's take community health workers. That's a role that's very heterogeneous across the United States. And that's probably a good thing, right? Because community health workers can adapt to what their role needs to be for the specific place in which they're being deployed. Right? Roles may differ for diabetic patients than trying to get mammography done or, bringing patients into the clinic for mammography. That's a good thing. But how do we train for a role that is so heterogeneous? How do we codify that? Do we certify it?
Press 0 now.
And moving from training for the individual health professional, we have to train teams to accept new roles. One of my favorite papers recently was a paper done by Ladin et al., and it's in the bottom down here, the Emerging Primary Care Workforce. It's the work from the LEAP project. And one of the things that they noted in their evaluation of these primary care teams is that other team members need to be aware of what this new role is, right? So far we've been talking about changing the role of the individual, but that individual is embedded in a practice or a health system or a context in which they're operating with other people. And if the other health professionals don't understand their role, A, and B, don't feel like they don't feel confident that the person's trained to do that new role, they're not going to delegate, right? If I'm a nurse and I don't know what that MA is doing, I'm not going to delegate. It's my license on the line, right? Or if I'm a physician and I don't know what that MA, what do you mean they're doing patient education? Do they know what they're doing? If I, as a physician, don't trust that you have the training that I need you to have to do that, I'm not going to delegate. So I need to understand and have confidence that you have that training so that I will delegate. And I need to understand how your new role fits within the general workflow of the practice, but also how your new role fits with my new role. So there's multiple layers here of trying to design education. And it's not just the education system that's lagging, it's the regulatory system is lagging. I want to give a shout out to the Dower-Moore-Langmuir paper, really nice paper in Health Affairs on restructuring health professions' scope of practice. And they point out the workforce innovations needed to implement the ACA programs require an adaptable regulatory system capable of evolving with the healthcare environment. And then they point out the health professions regulation system in place today does not have the flexibility to support change. So the education system is lagging, the regulatory system is rigid. And in order to create a more dynamic regulatory system, they point out, we need to develop evidence. We workforce researchers, we program and policy people need to have evidence to support regulatory changes, especially for new roles. We need much better evaluation of pilot workforce interventions to understand if those interventions are improving health, lowering costs. This is some seriously heavy-duty research needed. And we need to, they recommend establishing a national clearinghouse to provide up-to-date, reliable information about scope of practice changes. Why it is that, Nevada is going to do its own thing while North Carolina has already done that thing, 5 years ago, I don't know. So why don't we, as the Pew Commission originally recommended, have some sort of clearinghouse? So health system change rapidly, education lagging, regulation lagging, and last but not least, who's going to pay for all this retooling we need to do? Adequate and sustainable payment models to support new roles, train the workforce, retrain the workforce, support team and community-based practice and education are really lacking. If you look out there at the CMMI innovation projects, at some of these third-party payer projects, and other projects that I referenced earlier in the presentation, most of these are supported by one-time funds. So what happens? What happens if payment models don't change rapidly enough? If we don't move from fee-for-service to bundled payments, if we don't move from fee-for-service to more global capitated payments, will these interventions be sustainable? Will we be able to afford the care coordinator? Will we be able to afford the new role for the MA? I don't know. I wonder, where is a sustainable payment model to support these new professions? And from a very selfish standpoint on that last bullet, I wonder, are there adequate dollars available to help do the research and evaluations that we've talked about so far in this presentation? Is there money out there to really develop that evidence base needed to support workforce redesign? So those are some of the questions that we see. So in this presentation, we took you through kind of the new world and then the new questions we think we should be asking, and I really welcome your reaction to this redesign, not only of the workforce, but also of the questions that we as health workforce researchers should be asking. Thanks very much.
Thanks, Erin. That was great. Okay, at this point in time, we're going to go ahead and open things up for the Q&A session. Once more, ask questions using the chat panel on your screen, and please direct them to all panelists. Erin, I'm going to start you off with kind of really a few questions I'm going to ask you all at once. It's a little bit loaded. What about the public health? You're welcome. What about the public health workforce? How do you count them? How do you determine who's working in the public health workforce? How do we better integrate the public health and health workforce planning? How do we better integrate those things?
That's a great question, and that's, as I alluded to in my presentation, something that we've really struggled with here in North Carolina is who counts as the public health workforce. There have been some public health studies, but one of the things I think we could benefit from, and maybe you all want to do a webinar on it, is who out there is enumerating the public health workforce, and what's the overlap and intersection between the public health workforce and the functions that they typically have been charged with what? Absolutely addressing population health, right? I mean, the public health workforce has typically or traditionally been about addressing the population health, and then the individual practitioner has been, dealing with the individual patient. Now that we're talking about population health and the role that practitioners and practices play in population health, does that shift the role of public health, or does it change the dynamic between public health and the individual practitioner? I don't know. So I would love to engage in a discussion with you all about that.
Okay, Erin, here's a comment. It's kind of a question. It's not just about regulatory changes. It's about valuing the position enough to pay a living wage. Nurses' aides, PCAs, et cetera, correct?
Oh, that's a fantastic question. Thanks. So if we think about retooling the workforce, you're right. I've given the very global view here, but let's think about it from the worker's perspective. If I'm a personal care assistant or a home health aide or an MA, how do I enter the workforce, right? And then how do I continue to develop, right? Right now, we don't have good modular education for people to kind of move up and actually gain new skills. So one thing that we've been working with is a group called the Health Health Professions Pathway, H2P, and they're developing modular curricula to help people actually add on skills, and so that they can go from a very basic wage, add on some new skills, and increase their wage, because it absolutely is about a living wage. And it's not just about a living wage, it's about good working conditions, it's about satisfaction with your job. It's about all of these things. So I think that's a really important question that sometimes gets lost in the shuffle.
Okay. It's kind of a similar question. You may have already covered this to some extent. Where can we start retooling public health nurses, specifically to take on these new role of in-betweens?
New role of in-betweens. Oh, so that I think the question is about this role of managing transition and care coordination is how I will interpret that question. And if I've misinterpreted it, they can resubmit their question, make sure I get that. Or contact me directly. But this is a fundamental question, is where do nurses get this education? And I think this is one of the times where practices and major health systems have to be knocking on the doors of the community college system and the education system saying, we need curriculum for this. I know in my own, I'm in the Department of Family Medicine here at UNC, you know, our practices are transforming, and there's all sorts of need for not just retooling nurses, but retooling MAs. And so each practice is developing their own curriculum, which seems crazy to me. So this is my point about really making sure we connect healthcare delivery and the needs of retooling that they're encountering on the front lines, the needs of these nurses to learn how to do care transitions, care coordination, with getting some curriculum out there. And currently, I don't know about you all, but I'm not seeing that connection. I'm not seeing the education system being responsive to those needs. If I don't have an answer, I'm sorry.
That's quite all right. Another key question is, who will train the new existing workforce once the education system actually starts catching up? The existing educator base does not have any orientation towards this sort of healthcare delivery and roles. Where will the faculty instructors come from, and how will they get connected with the formal education system fast enough?
Oh, this is that chicken-egg question. It's such a great question, right? So how do you retrain people in these model practices that are really engaged in these new functions and team-based models of care and doing population health management if we don't have any faculty? If we don't have practices that are actually engaged in those fantastic redesigns, where do we put the students? But also, where do we train the people to do it? And so this is that chicken-egg issue. I think the Institute of Medicine has been working a lot on this, on their interprofessional education work. But the faculty, you're right, themselves need to be retooling as well. So I hope that I'm understanding the question, but that's how we see it, is this chicken-egg dilemma of trying to get the practices retooled at the same time that we get the education system retooled.
Okay, fair enough. Next question. What process would you recommend for identifying the change in skill set training needed in health systems becoming accountable care organizations?
You know what I wish we would do more of, and we had funding to do? Wouldn't it be fun to look at an organization before it becomes an ACO? So do a pre-post analysis of the workforce. Not just in terms of numbers, but in terms of skill mix and in terms of the content of practice. So I think we need more rigorous studies of this pre-post implementation. So I don't know what it's like in other states, but right now North Carolina is moving towards a lot of ACOs. And I've been out there talking to some of our major health systems about the fact that we could do this pre-post look at the workforce. So does the workforce, I'm going to contradict myself here, does the workforce look different in numbers? Does it look different in skill mix? And are the functions that are being required in an ACO type structure different? Is it demanding different skills of the health workforce? And I think more of those pre-post studies would be really helpful to understand the actual specific dimensions of training that are needed in that post-ACO world.
Okay, Erin, I actually have two questions here, and they're similar enough that I'm going to ask them both at once, so just bear with me. How do you address narrow scope of practice regulations that do not allow the flexibility for workers, PCA, home care aides, for example, to meet the new roles that these workers can play in care transitions and care coordination. And the next question, as roles change, how will we engage licensure boards? At the present time, most of our MDs and RNs are being taught in a model that is heavily prescribed by the licensure exams.
It's a great question, and I'm the one answering it, but somebody like Catherine Dower or Jean Moore, others are probably more skilled at answering this. You know, this is a fundamental issue, is I was trying to allude to it, is that we can't have flexibility for these PCAs and MAs and home health care aides unless the licensure boards, and particularly nurses, have confidence that they can delegate, understand that these people are adequately trained. And one of the things that our licensure board here in North Carolina is really wrestling with is how to help nurses understand, for example, when they're in a patient's home, how do they interact with the home health aide? How do they interact with the PCA? Because it's all about delegation. It's all about accountability. And so I think we need to bring the licensure boards into this conversation and in a very systematic and structured way, because we understand they have the responsibility of protecting the public, but they also have a responsibility to be flexible. And they also have a responsibility to understand that if these folks are adequately trained, that they ought to be able to do and practice to a fuller scope. And so I think the licensure boards would be easier to engage with, and the professional associations would be more likely to protect their turf. But I know it's not just a question for PCAs and home health care aides. You know, here in North Carolina, one of the things that I joke, and I hope I don't anger anyone out there, is that pharmacists are all about expanding their role and taking on new roles, but boy, let's not let those pharm techs have any other responsibility. So this is a fundamental issue, is that I think that's alluded to in that paper, is that, you know, the regulatory system is so rigid, and this is something we're going to have to just absolutely confront head on, and I think the paper provides some very concrete recommendations for how we might address some of that rigidity going forward.
Okay, Erin, how about this? What comes first? If we develop new roles, what about education and regulation? What about teaching folks to work together in an integrated environment? Where do we start?
I think we need to do them both at the same time, right? Because the health system pressures are so intense right now that the health system's going to move ahead, right? They're going to redesign, and they are redesigning their roles. So they're going to keep moving forward. I think the education system is going to have to try to keep pace with the health system, and that those two things are going to have to go in tandem. I'm less worried about that than I am that I don't think they're connecting. And anybody out there, if you have model examples of your health systems or your practices connecting in very productive ways with your education system, I would really welcome it. Because most of what we've read and we've encountered looking at this is that the education system really isn't that responsive. Or a local education or one university or one community college system is responsive, right? So they develop a curriculum, but then that curriculum is just for that one community college. There's no ability to transfer those skills. So back to the person who asked the question about living wages, what about giving certifications for different things like population health management or care coordination that's portable? So if I move from employer A to employer B, I can take it with me. And otherwise, I'm going to lose it, right? I have this role in this one place, but I can't take it with me. So I think both things need to proceed simultaneously, but that there has got to be better connection between the health system delivery, health delivery side, and the innovations going on there, and really harvesting what those training needs are and feeding it to the education system. Through what mechanisms, though, do we do that is a question. Is it kind of ad hoc, or do we develop a more formal way of doing that?
Thanks. Okay, another question. If we develop new roles, how will we identify standards in education and practice? Are there best practices out there already? Is anyone looking at this?
That's a great question. So I'm working with a group called the American National Standards Institute, ANSI, and a collaborative, a healthcare competency collaborative out there that is really trying to identify and codify some of these roles. So the reason being that if we can kind of codify the competencies and decide on what they are, then we could actually begin to develop training programs that train for those competencies. We can develop certifications for those competencies. So there are best practices, and you know what? Those best practices are outside of healthcare. I mean, this is what the rest of other other sectors do, is they, as roles develop, they codify them, they certify them, and they're out there. So the work that ANSI is doing in this healthcare collaborative, I'd be happy to share it with anybody who's interested in this, is all about that exact question, is figuring out what are these competencies so that we can train for them, so that we can certify them, so that we can be very clear what they are. And that clarity is going to help with explaining to licensure bodies what these roles are, explaining to payers what these roles are and why they should be paying them, and also explaining to educators how they should develop curricula to support them.
Okay, Erin, here's a statement that perhaps you could comment on. Working in teams requires training in teams. It is important to break down the silos at every level. Could you give us some feedback on that?
So that's what I was trying to get to on that slide about not only training for individual roles, but also training in team roles, right? So that's absolutely critical, but one of our problems that we find is that we don't have enough of these model practices where there are true team-based behaviors going on, right? So if we don't have those model practices, how do we train in them? And I think one of the things that the University of Minnesota group, the HRSA-funded group that's looking at is this team-based models of care and how to best develop and implement these. So I'm very interested in looking at the work that Dr. Brandt's doing out in Minnesota, and I think we all need to be looking at that work and trying to figure out what are the lessons learned around team-based training, and being aware that it's not just about training for individual competence, but training around team competence. Which reminds me, there was a slide that I took out in the name of time, but something that doesn't, I think, get enough attention are new roles like practice facilitators and quality improvement consultants and practice coaches. Those new roles are very much focused on building team dynamics. And so it's something that we in the typical health workforce research have not paid enough attention to, is what are those practice coaching roles? There's an evolving literature going on that shows that when you have practice coaches, that practices transform more quickly and they do it more successfully. And so I think we need to be thinking about those types of roles to facilitate team-based changes, because we can talk about it all we want, but to actually, when the rubber hits the road, someone's going to have to make that happen. And these practice coaches and practice facilitators have, I think, been integral in many ways to making that happen.
Okay, here's another question. Our health system is wrestling with the question of timing. When is the right time to begin shifting workforce into these new roles? We don't want to be too far ahead of the new payment models and jeopardize our sustainability.
I love that question, and to the person who asked it, that's what I was trying to get at, was what happens if the payment model doesn't change? I was giving a lecture to some students here at Carolina the other day, and one of the students said, what if we never achieve this, new utopia of payment policy? What happens then? So how do you adapt the fee-for-service model in some way to pay for these new roles and functions? And so is it some sort of blended payment model? And I think that blended payment models may in the short term be that bridge between fee-for-service and some of these more innovative payment models that will enable us to move. But I have such sympathy for the person who asked that question, because frankly, I've just given a talk on new roles and the future. If I were a health system gauging this, I'm not sure I'd move yet. Because I'm not seeing the payment models changing rapidly enough to support this kind of system transformation.
Okay, here's another question. What happens when you present this material to the countries and states' workforce investment in regional boards? that are formally charged with aiding employers and workers in getting training?
There's a lot of interest out there actually on the Department of Labor side and workforce investment boards on this, because one of the things they're charged with is basically being very focused on kind of community college education and really being aware of what are the roles and emerging health jobs in their community. And so they're paying quite close attention to this. And there's a fair amount of interest at the community college level the community colleges are very tight partners, right, with the workforce investment boards. A lot of interest in developing these curriculum, because think about it. Whoever is able to develop the ability to retrain the workforce, whether it's the community college system or AHWTAC, AHWTAC's also sitting in a great place to do this. What is AHWTAC about? They've always been about continuing education as one of their primary missions. And so what is their role in developing these curricula? And I think they're very responsive in trying to understand, okay, what are these roles? What do the employers want? Because that's where workforce investment boards are very focused on the employers. Okay, employers, what do you need? Do you need a care coordination curriculum? Do you need a curriculum on training MAs to do population health management? Do you need a curriculum on, we had the other day, somebody call and say, where can I get a curriculum on teaching MAs how to do patient education? So I think they have a very active role in this vis-a-vis where they sit and their responsiveness to employers and their attachment to the community college system. So I'd say that they may be a very important group to be working with.
Thanks, Erin. One more question. One problem we've seen in the past is that as new workforce types develop in response to health systems change, each develops a professional organization of their own to advocate for their recognition, inclusion, etc., then tend to become another inflexible piece of the puzzle. How do we prevent this?
I have no idea. That would be a really interesting dissertation topic, actually, to look at the evolution of professional associations and their definition of themselves with new and emerging. I honestly, I'd have to go away and think about that. But, you know, I wonder if you could look back at some new roles as they emerged and look at the evolution of the professional association and their mission and advocacy. But that's a great question. Sorry, I don't have a better answer.
Okay, well, I believe that's it. Thanks, Erin. The presentation was great. We got a lot of good feedback there. And thank you out there for attending our webinar. Just to let you know, we will be posting our slides shortly to our website. So if you want to download them, check back very quickly at healthworkforceta.org. We hope to see you again in the future. Thank you, and have a good day.